I've said so when the count is normal but the function is abnormal, it's thrombocytopathy. Okay, so it can also be an inherited condition, and some acquired condition can also be responsible for whether the quantity and the quality will be defective. Okay, so in the process I will talk about the inherited platelet disorder. I've decided to use 150 to 400 or 450 because that's the textbook stuff. Textbook stuff. But I just wanted you to know that it may not be correct in our environment. Okay? So this is how it is classified: qualitative platelet disorder, quantitative platelet disorder, and qualitative. So there are some causes of quantitative disorders. And as you can see, it can be due to abnormal distribution. We'll talk about that. Dilution effect, we'll talk about that can affect the quantity and brings it down. Then decreased production can also, like in leukemia, and increased destruction, like in ITP. The platelets are produced, but they are peripherally destroyed, and then it causes thrombocytopenia. Okay, so also qualitative disorder can be due to inherited causes, which we are going to, I don't know whether it was mentioned last week, inherited causes of platelet disorder. Bernard Solio, Ben Glanzmann thrombocythemia was mentioned. Okay, we'll talk about it if it wasn't mentioned. So it could be just isolated thrombocytopenia. White cell is normal, hemoglobin is normal, every other thing is normal except platelets. It's called isolated thrombocytopenia. And in this environment, these are the causes. Uh, Chemotherapeutic drugs can just target the platelet. But as a hematologist, when I say isolated thrombocytopenia and a lady, the first thing that comes to mind is ITP. ITP, immune thrombocytopenia. You see isolated thrombocytopenia in a lady because immune disorder is commoner in females than males. So, but these are the other causes. Radiotherapy can just target the platelet alone and bring down the platelet count. Infection can also do that. It could be pancytopenia, like we discussed the last time. All the cell lines are depressed. To have a mnemonics for 5 years, myelosclerosis, which we are going to talk about, is like the sclerosing of the bone marrow or fibrosis of the marrow. Myelodysplasia, the cells are abnormally formed in the marrow and they are destroyed before they are released into the peripheral blood. So we'll talk about that too. Multiple myeloma, we talk about that in your third block, all the hemato-oncology cases. Marrow infiltration from leukemia, whatever. So it's going to disturb thrombopoiesis, you know. So megaloblastic anemia can also be responsible for pancytopenia. So other causes of general marrow depression include HIV infection, radiotherapy, and cytotoxic drugs can be responsible. So these are the causes of thrombocytopenia. Increased consumption of platelets, like DIC, disseminated intravascular coagulopathy, which we are going to talk about. DIC, this is just a brief introduction to, just for you to know, causes of reduced platelet count. TTP, we are going to talk about TTP, thrombotic thrombocytopenic purpura, TTP. So TTP and HUS, they look alike. HUS What hemolytic uremic syndrome? TTP is like thrombotic thrombocytopenic purpura, and DIC is. So what are the differences? They cannot cause thrombocytopenia. The mnemonics for the three is fat registered nurse, fat registered nurse. F is fever, A is anemia, T is thrombocytopenia, R is renal impairment, N is neuropathy. So renal impairment is present in one of them, it is not present in the other. Neuropathy is present in. So those are the diagnoses that can cause low platelets, reduced platelets. DIC, TTP, HUS, increased consumption of platelets will cause reduced. So autoimmune or ITP, like I've discussed, or idiopathic thrombocytopenic purpura, ITP, is also, like I said, is commoner in women between 15 to 50 years. There is isolated thrombocytopenia, normal WBC, and normal hemoglobin. So it can also be due to drug. Medication can reduce platelets. Drug-induced thrombocytopenia. There are some drugs that have been implicated, in reducing platelet counts. And as you can see, some of them are listed: quinine, NSAID, so diuretic like furosemide, antibiotics like penicillin. So platelet is destroyed as an innocent bystander. There is the drugs combines with like combines with plasma protein as an antigen, and then immune complex is generated. Platelet is on its way going. That immune complex now destroys the platelets. So that's the mechanism. Rifampicin is anti-tuberculous. Then some anticonvulsants like carbamazepine, uh, sodium valporate, heparin, and abscimab. Abscimab is what? Antiplatelets. So they can also cause low platelets. It's also possible, like you have rhesus hemolytic disease of the newborn. You could also have neonatal immune thrombocytopenia, NAT, neonatal immune autoimmune thrombocytopenia. Is similar to rhesus hemolytic disease. We are familiar with the mechanism, the pathogenesis of rhesus hemolytic disease of the newborn. And then the difference is that firstborn could be affected because human platelet antigen, is present on the platelet, and there are various types of human platelet antigens. Could be 1A, 1B, 2A, 2B, 3A, 3B. So it crosses the placenta, human platelet. If so, if it crosses the placenta and the baby develops an antibody that lacks that antigen, develops antibody to that human platelet. The culprit is 1A, human platelet antigen. So the antibody destroys the baby's platelets, you know. But if the baby has that same antigen, so there will be no antibody development. But if the baby lacks that antigen that the mother has passed on to the baby is going to develop antibody to that antigen, and that antibody binds to the baby's platelet and destroys it. So human platelet antigen is like I said, so that's like an army. So human platelet antigen 1A is found in 98% of general population. And it could be the other way. If the mother lacks human platelet antigen 1A and the baby has human platelet antigen, so the mother can pass the antibody to the baby, and then the antibody can destroy the platelets of the baby. It's called neonatal autoimmune thrombocytopenia. So there's a video for ITP. I brought it, we can play it later. So there are two types of, I want to talk about immune thrombocytopenic purpura. I prefer to call it immune because antibody is acquired, autoimmune, from the person involved. And the antiplatelet antibody destroys the person's platelets. You generate, so we see a lot. And somebody that has autoimmune immune thrombocytopenic purpura also has rheumatoid arthritis, also has systemic lupus erythematosus. So, these are antibody problems. Okay, so we see a patient we are managing in hematology, also attending rheumatology clinic for SLE and ITP. So, but our drugs are essentially the same. We use the same drugs for the two. We use steroid for ITP, and then we use rituximab anti-CD20 for ITP. So, there are two types of ITP actually. We have the acute type and then the chronic type. You can see the difference. Acute ITP is seen in children 2 to 6 years. It has no sex predilection, and unlike the chronic, which is seen in from 20 to 50, 60, and then it's commoner in females, 3 to 1. So, like I said, if I see an isolated thrombocytopenia and you are a lady, the first thing that comes to mind is ITP. Okay, so it's insidious, starts gradually, and then, but in acute, it's abrupt. Then platelet count is like less than 20,000, and usually it can be zero in some people. It can be zero, yeah, but usually low. So eosinophilia and lymphocytosis is commoner in acute and rare in IT chronic, and duration is 2 to 6 weeks because acute ITP is self-limiting. You may not do anything and just resolve, but unlike chronic, you must intervene. So it's a lifelong problem because the person is developing antibody and there's nothing you can do about that. So you have to either continue to place the person on steroid to bring the platelet count, and then of course in 80% of cases that's spontaneous remission. It's very rare to have a remission without intervention in chronic ITP. Okay, so this is the classification, can be mild depending on the platelet count. So if the platelet count is between 50 to 100, that's a mild, ITP. Like I said, cutoff is 100 in this environment. So, but we are going to be discussing platelet transfusion therapy maybe later in your third block. Will be how do you manage a case of thrombocytopenia with platelet concentrate. So the moderate the moderate ITP is between, platelet count is between 20,000 to 50,000, and then severe ITP is usually less than 20,000. Okay, so but if the patient is not going for surgery and then platelet count is say 40,000, we usually don't intervene. The goal of management of ITP is not to bring the platelet count to 100,000. So the goal of management is just to bring the platelet count out of danger level. So, but if patient is less than 20, if the count is less than 20,000, then you must intervene. But in ITP, unlike other causes of thrombocytopenia, you don't give platelet concentrates. Why will you not want to give platelet concentrate? It will destroy the platelet you are giving now. So except it's in their emergency, you don't care whether it destroys it or not. You have done the platelet count, full blood count for a patient, and platelet count is 1, not 1,000. What's the implication if you don't intervene? What's the implication? Intracerebral hemorrhage. And if the patient bleeds into the brain, then It's a vicious cycle. So even if you have platelet concentrate and the patient has confirmed ITP, then you just give, but it's going to be destroyed, but you may be lucky to bring the patient out of danger. So this is what happens in ITP. The antibodies, look at the antibodies, binds to the platelet and then takes the combination to the spleen, and then the reticuloendothelial cells destroys it, and then so you can see that the antibody binds to the platelet and then takes it to the spleen, and it is destroyed in the spleen. So these are the other causes of abnormal distribution of platelets. Okay, so abnormal distribution of platelet can cause thrombocytopenia. Okay, so normally the platelets is may be pulled at once in massive splenomegaly. So ordinarily 30% of the platelet count is found in the peripheral blood. So if you have splenomegaly, okay, it can be pulled in the spleen. So platelets will be pulled into the spleen in splenomegaly and will causes a fall in the platelet count in the peripheral blood. So splenomegaly, any cause of splenomegaly can cause pulling of platelets into the spleen and then reduces the count, peripheral count of it. So if you have splenomegaly, hypersplenism, you can cause thrombocytopenia. So can also result from hypersplenism. The difference between hypersplenism and splenomegaly, or the difference is one is structure and function. So splenomegaly is increased, but function is not affected. Hypersplenism, function is increased. It can be normal size, it can be the same size, it can be bigger size. So they can all cause thrombocytopenia. Okay, they can all cause thrombocytopenia because due to pooling of or abnormal function in the spleen. So there is what is also called pseudo thrombocytopenia. That's false low platelet count. So there are some, like EDTA is known to, you know, coagulate the platelets. When you bleed the patient into EDTA bottle, it can clump, and when you do a full blood count, it will be presenting as low platelet thrombocytopenia. So some anticoagulants can cause platelet clumping, but in vivo, from where you've collected that sample, platelet count is normal. But in vitro, because of what you have done to the sample, you do a full blood count, you'll be getting a platelet count lower than what is in the individual. So it's called a pseudo thrombocytopenia. So there are other anticoagulants that can also cause pseudo thrombocytopenia, like citrate, ACD. What's ACD? Acid citrate dextrose can also cause clumping. Oxalate, heparin, all these anticoagulants can cause platelet clumping. And then if you do a full blood count, you'll see that the platelet count. So you can do corrected platelet count can be obtained by sampling finger stick. Just do a finger stick prick, then press out the blood straight into the slide, make a smear and stain. So you'll be able to confirm that it's truly trouble. So how do we estimate platelet count from high power field? You make a smear, make a stain, so you can estimate. So at high power field, one platelet count is what? 20,000. 20,000. So you can estimate. So if you are counting 4, 5, 6, 7, so you just multiply by 20,000. So you can estimate whether it is truly a pseudo thrombocytopenia due to anticoagulant effects that has caused clumping or not. Okay, so there could also be dilutional loss. Okay, the explanation to this is that in what's massive blood transfusion? Transfusion of the total blood volume of the individual within 24 hours. Okay, you want to transfuse, so total blood volume is what? 5 liter for everybody. We are going to have the same total blood volume. Why? Age and sex. So it cannot be 5 liters. So it should be in mils per kilo. So they want to. So what's the normal reference for in mils per kilo? Usually 60 to 80 mils per kilo. So you multiply by your kilogram, and so you can get so. So the challenge that if you are doing massive blood transfusion, you are transfusing total blood volume. So assuming I'm 5 liter, so how many pints of blood, if I need to be transfused massively within 24 hours, how many pints of blood will I be given? 10 units, okay. 10 units, and to get 10 units within 24 hours, you will need to rely on stored blood. It's not easy, except you don't want to do screening. So I will tell you the process of screening. So when they bleed patients in the morning, around 9, 10. So they wait till like 12:01 when they will now send the sample of those people bled for screening for HIV, hepatitis B, hepatitis C, and hepatitis syphilis and syphilis. So they do ELISA. They do pre-donation screening with a rapid kit. They do pre-donation, means that they do a pre-donation screening for HIV, hepatitis, and all the syphilis. We have a rapid kit that can give you results in 10 minutes. So, and then they also do hemoglobin, PCV. Those that are not fit are screened out. Those that are fit are bled. So after bleeding, they pull the samples together. They wait for like 40 samples for 40 donors, because the ELISA can run 40, 96 at once, 90. So they cannot be wasting heat. So they wait till like 12:01. So and the process takes 4 5 hours. ELISA takes 4 5 hours to get results. So by the time the results of ELISA is ready, it's like 4 5. So to get a fresh blood, you need to wait that same day blood. You need to wait till like 5 in the evening, or except you want to give unscreened blood. So rapid kit for screening is not as sensitive as ELISA, because some will still be missed, and that is why it is no longer acceptable in any part of the country to use rapid kits for screening. So it must be ELISA. ELISA is enzyme linked immunosorbent assay. So it is very, very sensitive. It will even pick you as positive for HIV when you are negative. It's better you are picked up as positive for HIV and they discard the blood than miss the blood and then you get transfused with HIV blood. So I want to go back to my former statement that I'm going to be transfused 10 pints. And it has to be the group specific, group compatible. So it may be difficult to get, and I'm not the only patient in lawsuit. So there'll be requests from everywhere, O&G. So there is a challenge. You cannot get fresh whole blood. So you rely on old stored blood that were not used a day before, 2 days before, 3 days before, for me to get 10 units of blood. Okay, it happens in Aike when patient have DIC after delivery, just pouring blood. It's like opening tap. Yeah, opening tap or PPH, postpartum hemorrhage. So you need to be, running helter skelter to give blood. So in the process, platelets are destroyed at fridge temperature. So when we produce platelets, we put them on the shelf. We don't put them in the fridge because their best storage temperature is 22. Your domestic fridge at home in the hostel, what temperature does it operate? I know some of you have fridges. It's 4 degrees, 4 degrees. So your domestic fridge is 4 degrees. Your domestic freezer is what? -20 is -20. So, but platelet is destroyed at 4 degrees. Okay, but you are picking blood for transfusion from the fridge, a blood that has been stored 2 days, 3 days, 4 days. So that will be depleted of platelets because they are destroyed already. So and then you are giving 10 units to the person. So you are giving platelet depleted units. So it will be diluting out the little platelets the patient. I hope I've explained it clearly. So I hope I've explained it clearly, except those that were sleeping, and I'm not going to go back. So it can be prevented by, so if you are doing massive transfusion, because you are relying on old stored blood, so and then you don't want to cause dilutional platelet thrombocytopenia, you can intermittently give platelet concentrates to prevent that. So thrombocytosis, when it's higher than 450 or more, there is what is called essential thrombocyte, essential thrombocythemia or thrombocytosis. So essential thrombocytosis is like polycythemia vera. What's polycythemia? You did that when you are, say, uncontrolled production of the red blood cells due to JAK2 mutation. Were you informed about that? So there could be JAK2 mutation affecting platelet production to thrombopoiesis. You now have a platelet count of 1 million, 1 million, 2 million. So, but occasionally you could have reactive thrombocytosis. So this condition can cause sustained rise in platelet levels as high as 700,000, 800,000, 900,000, 1 million, all myeloproliferative disorders. So essential thrombocythemia is a component of myeloproliferative disorder. Polycythemia rubra vera can also cause elevated, because JAK2 is also involved in the pathway. Don't forget it's from a common progenitor. If you have done that, granulocyte monocyte colony stimulating factor. So it's going to stimulate everything, and then you have CML can also cause thrombocytosis. We are talking about thrombocytosis now, reflex thrombocytopenia. And then we want you to differentiate between malignant thrombocytosis, which is usually called thrombocythemia. So if it's higher than 600, any platelet count higher than 600,000 is usually malignant and usually caused by MPDs, myeloproliferative disorders like polycythemia rubra vera, chronic myeloid leukemia, essential thrombocythemia, myelofibrosis. So platelet count is usually more than 600,000. Okay, so it can be all those causes. But if it's between 400 to 600, these are the causes of reactive. It's called reactive. Okay, hemorrhage. The patient is bleeding. Why should the platelet count be increased in hemorrhage? Who can think of it? Why should the platelet count? I've listed number one as a cause of thrombocytosis. Hemorrhage as number one. What is the pathogenesis of thrombocytosis in hemorrhage? I'm not asking for the reason why there should be thrombocytosis. I'm talking about the pathogenesis. Why should, how should, what is responsible for thrombopoietin? How is it related to hemorrhage? No, I'm not talking about platelet count dropping. I'm talking about hemorrhage. Okay. Okay, you have idea. Thrombopoietin has a structural similarity with erythropoietin. So, and vice versa. So when there is hemorrhage, body will produce erythropoietin and then stimulate platelets in the process. So that's because of the structural similarity between thrombopoietin and erythropoietin. Okay, that's the reason I wanted to hear from you. So, and then it didn't come. So then trauma also can cause, but when even in hemorrhage, your platelet count will not be 1 million. Oh. It can be 600,000, 400,000, but there is no, it's not sacrosanct. It cannot be 1 million. So if it's 1 million, then you start thinking about what myeloproliferative disorders. So these are the other causes. Iron deficiency can also cause. It's also the same mechanism, erythropoietin. So all this can cause post-splenectomy. Why should splenectomy cause thrombocytosis? Huh? Like I said, 30% of platelets is stored in the spleen. So if you remove the spleen, the 30% will be released into the circulation. So when you do a full blood count, you are only counting 70% from the peripheral. 30% is normally, and that is what is responsible for thrombocytopenia in splenomegaly. In splenomegaly, the spleen will pull more than 30%, 60%, 90% of the platelets will be pulled into the spleen and then will cause thrombocytopenia. So similarly, if you remove the spleen for whatever reason, then there will be no. So in post-splenectomy, if you write a consult to hematology, come and review platelet count of 700, just this person doesn't know what he's doing. What else do you expect? You know, because you have removed the spleen that normally stores 30%. So where would the 30% be? It will go into the circulation now. So that's the explanation for post-splenectomy thrombocytopenia. So qualitative platelet disorder, like I've said, the platelet count is normal, yet patient is bleeding, and it's not due to coagulation disorder, it's a platelet type bleeding. So what are we know the platelet type bleeding and the coagulation type bleeding? What are the platelet type bleeding that we know that will cause, or how will they manifest? Platelet type bleeding, mucous membrane bleeding, petechiae, opera, ecchymosis. Then a female can have menorrhagia during menstruation. So platelet count you have done is normal. Platelet count, unlike ITP, platelet count is 20,000. This is the cost now, but you have done platelet count is normal, 300,000, 400,000, and you did the bleeding time and it's 20 seconds. I mean 20 minutes. So it has to be with the quality of the platelet. So other conditions that may cause normal platelet count and prolonged bleeding time are von Willebrand disease, and they mimic it. Von Willebrand disorder can also cause it's because it's involved in primary hemostatic plug. I don't know whether primary hemostatic plug has been discussed. So von Willebrand disease, if von Willebrand factor is deficient, will also affect the adherence, agglutination of platelet to the. So these are the heritage, not too clear, but it could be autosomal recessive, autosomal dominant, and then so it has to do with the glycoprotein of the protein, deficiency of glycoprotein 1B. We know about glycoprotein 1B, 2B, 3A, Okay, so 1B deficiency is Bernard-Solio. Some people, inherited deficiency of glycoprotein 1B. Some people, so it's going to affect addition. Some people inherited deficiency. Yeah, of okay, okay. Some people inherited deficiency. You admire that. I saw it. What not me because you are used to my own dress. Bernard-Solio. I want to don't worry about this one. Bernard-Solio. So Bernard-Solio, Glanzmann's disease. Bernard-Solio is glycoprotein 1B deficiency. Glanzmann's disease is 2B3A. There could be storage pool, alpha granules defects. These are the content of platelet, alpha granules, delta granules. So there could be deficiency of those, and it's going to affect the function, but the quantity is the same, is normal. Okay, so these are the hereditary causes. Delta granules deficiency. Some people have inherited deficiency of delta granules. Delta granules is the content of the platelet. We are not mentioned, it wasn't mentioned. Delta is also another granules present in the platelet. Okay, apart from alpha granules, we also have delta granules. They have substances that they secrete, serotonin and the rest and the rest. Okay, then there are some enzymes in the platelet can also be deficient. So, so this is Bernard-Solio. Like I've said, Bernard-Solio is deficiency of glycoprotein 1B. So, resulting in deficiency of platelet binding to von Willebrand factor and then addition to subendothelial microfibrils causes various degree of it causes thrombocytopenia apart from thrombocytopathy. So it is autosomal recessive inheritance. And ordinarily platelets should aggregate with this substance erythrocytin, but because of the deficiency, there is no aggregation. So there is this Glanzmann thrombasthenia, which is also deficiency, inherited deficiency of glycoprotein 2B3A. So, and can also affect the quality of the platelets. Okay. So what is expected of you is that you know that Glanzmann thrombasthenia is 2B3A. You should know that Bernard-Solio is 1B. Okay. Those are the hereditary deficiency. So these are the other, there could be membrane defects, like defects in response to collagen because of abnormal phospholipid in the membrane. Okay. In the type 1 Willebrand disease, there is increased erythrocytin induced platelet aggregation and von Willebrand deficiency in plasma. And because von Willebrand is also needed for platelet plug formation. So if there is deficiency or if there is a problem with the membrane of the platelet, there is defective phospholipid in the platelet membrane, is going to affect the function of the okay. Well, okay, maybe it's an error. I will check and get back to you. It could be typographical error. Okay, these are the other platelets, inherited platelet disorder. Gray platelet syndrome is absence of alpha granules and the content is rare. Okay, delta storage, there is deficiency of dense granules or delta granules I've told you about. So it is commoner than gray platelet syndrome, which is alpha granules. Delta storage disease and albinism together is known as Mansky-Podlack syndrome. So if you have delta storage disease, these are the inherited platelet disorders. So it could be some enzymes that are present in the platelet that are deficient, cyclooxygenase deficiency, thromboxane. These are enzymes that are present in the platelet. They are also inherited. So these are the various inherited type of platelet disorder. Thromboxane synthase deficiency. Okay, they are all called storage pool because it has to do with this content of the platelet, the storage content, the delta granules, alpha granules, the enzymes. They are all called storage pool disease. They are all inherited. So there are acquired causes that can cause drugs, like I've said, can affect the function, but the quantity is normal. The antiplatelet drugs, prostacyclin, sulfentrazone, dipyridamole, dextran will affect the function, and then the glycoprotein 2b3 inhibitors like epitifibatide and torifiban are inhibitors to glyco. What about aspirin? Low dose aspirin. Sorry, I know how does it work. Cyclooxygenase inhibits cyclooxygenase enzyme. So there are also condition other cyclooxygenase enzyme which is needed for the platelet function. So affect platelet adherence, release, and hyperglobulinemia, multiple myeloma, and also affect the function of platelets. Okay, MPD, myeloproliferative disorder, MDS, myelodysplastic syndrome, will also cause abnormal platelet function. Uremia can also cause bleeding due to abnormal platelet. These are the acquired causes of antiplatelet drugs I've mentioned: aspirin, clopidogrel, and non-steroidal NSAID will also cause abnormal platelet function. I mentioned hyperglobulinemia, multiple myeloma, Waldenström macroglobulinemia, heavy chain disease will cause abnormal platelet function. MPD, okay, I've discussed this. So these are the other causes of abnormal platelet disorder. Okay, heparin, alcohol, radiographic contrast agent, antiplatelet antibody like ATP can bring down the platelet count and also affect the quality. Sorry, well, mechanism may not be known, but alcohol can cause anything. Okay, uremia, I've mentioned this. Heparin in high doses inhibit platelet aggregation. Alcohol and radiographic contrast agent causes defective function. Mechanism may not be known. So I think that's the end of the lecture. Can stop it. So I think